We're live. Oh my gosh, here we are. Maybe.
You're live, Kat.
Guys, say something. Lisa.
It said it.
It says it's live. Hi, everyone.
Yeah, we're live. We're live. Hello, everybody.
Happy Friday.
Hey, Kat. Hey, Lisa. Hi, Mr. FOMO.
Oh my God.
Hey, Neil.
Yeah.
Neil, I'm
Mr.
Mike.
FOMO.
I've missed out for a while, so I'm scared of missing things.
Well,
Yeah.
we're back.
Okay.
It's been a long week for some of us, and let's spare our friends here and send them in the background, and so they don't. I know someone needs to go and take a nap, and it's me. Just kidding.
Yeah. Well, yeah. So Neil Patel, real life investor at Redesign, he's going to tell us all about AI. I think it's unclear, but we're excited to hear his real life thoughts. But in the meantime, we're going to get ourselves in trouble. So Neil, wave to your loyal fans, and we'll bring you back.
Hi,
All
fans.
right. Okay. Michael, what do you have to say for yourself?
I'm in career crisis, so if you have any counseling services you can point me at, feel free to send me that way. So I
Loyal
texted
fans.
you offered, and then your travel day just disappeared. So
She's a
I
busy
appreciate
woman.
the offer, though, Kat.
Oh, yeah. Can you just text
It's
me your
okay.
question? Because I got that on an airplane and it didn't work out.
I figured it didn't
people.
work out, Kat. It's okay. You're a very busy person. You've got no internet. I don't know what's going on, but it's okay. It's okay. Maybe I'll catch you in DC at the ASTP. ONC.
Yeah. I'll say I'll be around. I will be in the location. It's unclear if I will actually go to the location of the conference. But
That's okay. That's okay.
yeah, but Melissa will be
definitely
there.
true.
I
Melissa
will
likely
exactly
go.
at the
so.
location of the conference. So
Oh, awesome.
Would you like to talk? Would you like to talk to our loyal fans about your career crisis? Do you want to group source some, crowdsource some advice?
if any, let's just put it this way. I'm having some second thoughts about what I'm doing next in my life, and so unfortunately, some things have changed here at Sutter, and I'm just taking stock. It's a new year. It's a new me. I have one less appendix. I've spent 5 days in the hospital. I've got a new hip. I mean, all sorts of stuff going on here. It burst during surgery, Kat. I had stuff in my innards. So anyway.
Okay.
So
That sucks. But can I just tell you, I have a lot of lady friends currently getting body parts taken out of them because that's
I've had
what happens,
several.
I think.
I've had several.
When you turn 40 and up, and the motto of all of my mom friends is that the key to happiness in 2026 is subtraction, not addition, including body parts. So
Good.
I feel like it's fine.
It's fine. The interesting thing is that I went home. If you've ever heard of a JP drain, you talk about, we work in high tech. They actually stick a tube in your gut to make sure that your surgery actually worked. And if it doesn't work, then things come out in this little tube that they give you. Just look it up, internet, JP drain. So I had a tube for like 7 days coming out of my gut to tell me it's a canary in a coal mine. If something's wrong, the wrong color stuff will come out. And if everything's okay, the right color stuff comes out. So, being in high tech, having a low tech device implanted in me was quite interesting. So anyway, I'm transparent. Me.
I'm loving your oversharing. I think it's great. I am looking forward to hearing what our AI expert in health tech thinks about this very low tech endeavor. But okay, Michael, we're gonna send you to the back for a little while.
Yeah, send me back.
We're gonna send you to the back. Melissa, any news to report?
No, we are down to 2 shows at Vive, guys, and I'm getting some sponsors. So I'd like some outreach in completing this. So if anybody's interested, please let me know. Booking rapidly right now. Other than that, I'm trying to get into my LinkedIn account and just realized my 16-year-old created his own and I can't figure out what to do to get him off of mine. So I'm trying to do that. So kick me off.
Cool.
So I can figure
Technology.
it out. Monitor this.
Technology. Yeah. Lisa and I both have been asked to speak at a bunch of things at Vive. So therefore we can't do all the shows we thought we could. So anyway, that's fine.
It's like people wanting us to do like a real job, and we're like, we have a fake job.
Wait, what if we're coming for our fake job?
Yeah,
the one
please.
that makes no money.
No, we're coming for our fakes and our real jobs now because we're also speaking like
I know.
officially at the event, not just to, the media clowns. We're like,
I know.
they're making us do like real things now, which is crazy.
I know. We have to use our brains and not just shit talk on the internet
Yeah.
for several hours.
That's some BS right there. I was hoping to just be like a party clown and now I have to do actual work. Whatever.
Yeah,
I mean, thanks Vibe, but also whatever.
We'll do what we can. All right,
Yeah.
Melissa, we'll send you in the back. All right, Lisa, we got to move on. We just had a lot of body parts talk. We got to move on to some health tech policy.
Oh my gosh, seriously.
Okay, let's see if the internet holds up here. So it sounds like we may not have a government shutdown again.
Listen, I mean, I certainly hope that is the outcome because a government shutdown is, as we have established multiple times, a very bad idea. Like so dumb, doesn't save money, doesn't do anything, really screws up everything. So like, please.
Yeah, I did read that there are some hiccups. There are some hiccups happening with this deal. So like, let's just hope that it happens.
Yeah, well, what they were trying to do, just to be clear, was carve out, the DHS ICE funding and, do other stuff. They're still talking about, cost sharing reductions and all kinds of whatever. They're throwing them all together. But I do appreciate that Congress appears to remember at least a little bit that they have a job. So TBD.
Yeah. Congress does seem to be awake today, and they seem to be awake yesterday. This is exciting news. All right.
Yes.
What else we got? Okay. This looked like exciting news, but I would like to dig into it. This was CMS announcing that the large primes that are already working in the states on Medicaid eligibility systems have agreed to give the states $100 million in discounts, credits toward work requirement build out in those states. I have thoughts. What are your thoughts, Lisa?
So so first of all, as we know, the administration has been very clear that their message is their plan is to like get, industry folks, get, companies, contractors, health tech vendor, whatever, to like come to the table voluntarily and all this stuff, like whatever it is across all their policy areas. They're like, regulation takes too long, doesn't work anyway. Like, this is what we're going to do. And I get it, right? Like they've been very clear that is what they are trying to do. My own company's been part of that. You've been like around those, whatever. Here, if you double click into this one, they're saying basically that the companies who work with Medicaid eligibility and enrollment, that is like the companies that have the tech platforms that, if you're going to implement, let's say, work requirements or community engagement requirements, you need to add those new policies and rules into the eligibility and enrollment systems to actually make it work. And if you ever work with a big old government tech contractor, you know that it costs millions of dollars and takes a really long time to get anything done. So like, adding one button that's like, is this person meeting the requirements, could be millions of dollars. So they're saying that these companies have like agreed voluntarily to like provide discounts to states. And the amount that they quote is like $600 million. I forget. What is it again? It's not a lot of money.
It's not a lot of money.
But 600 million.
It's more money.
It sounds like that's a lot. Yeah, it's more money than I have, but it's not a lot when you think about 50 states plus the other Medicaid programs. Like, it's actually not a lot of money. So like, I'm like, cool. Did you give like a 5% discount? Like, what are we talking about here?
Yeah, I have a lot of thoughts. One is that
we had a smart thought from Sarah, who's a smart lady.
Stop it, Sarah. That is what I was gonna say.
Oh, Sarah, you got her. Her.
No, listen, here are my feelings about all of this government smackdown over the past year to whatever it's gonna be. Is that like a lot of us, including me, like, you lose business, right? It sucks. You have to evaluate how you do things, and do you do it differently? And for a lot of these big primes, like, honestly, that were sucking the fat off of the government for years and years and years, they had to rethink how to do stuff. And that also means that in some cases, these companies go away and small innovators can go in and do amazing things. So I was actually really freaking pumped about this, about like the states. I wasn't pumped about the states not having money, to be clear, but lower budgets, big requirements, and the primes not being able to do it cheaply and efficiently. I actually did think, okay, this is a silver lining. And then they go and like give a deal to the big primes who are again still just sucking the life out of America. And they're like, oh, don't worry. They gave us a small, like overall, it's going to be an extremely small discount on what this work is going to cost. Like, oh, did I pause up? Or Lisa paused
No,
up?
no, no,
Anyway.
no. You're good. You're good.
No, but like,
I just sitting there. I mean, I'm agreeing. I'm nodding and agreeing with you in my head here, at least, because I just,
like I
come
do
on.
think this sucks. Like if this was like,
Yeah.
I don't know.
Yeah.
I'm bummed about it. And I mean,
I'm with
a
you.
lot of the reasons these systems don't work is because they were built state by state, because that's more profitable than building a system that scales. And you can have all kinds of arguments about that. Michael, go away. Go away.
What is happening?
I don't know. But like, yeah, like they're part of the problem and we just gave them a gimme. And maybe that's because of lobbying. I don't know. But I think this sucks.
Yeah, I feel bad about this. So what CMS will probably say in response to that is like, okay, well, we have a list of people who are doing it right now, and then we have like an interested parties list, which is longer, of like more like smaller, less established companies. Fortuna Health is on that list, who are not already on the GSA schedule. Schedules like that serve to keep smaller players out. They are like the the administrative barriers to more innovative technology, newer companies being part of this work. I just think like you got to rethink the whole eligibility and enrollment thing. And as Sarah had said, they like they did a really bad job. Like, spoiler, look at the results. Whenever they tried to, eligible enrollment anyway before community engagement work requirements were required, has already been like a huge mess and really complicated and like not good. And people get kicked off the rolls all the time for dumb reasons, like just administrative, like mistake and technical mistake reasons. So it just pisses me off. Like I understand why CMS did this, but I don't think this is the win that we might hope it is.
Yeah. Like I get it. Like, I think it is a law, right? That this has to be
Right.
2027. This shit has to get started January 1st.
Right away.
That's all right. That's not CMS's fault. And so I do think, given the time constraints, a lot of them are going to have to use their big primes, and the big primes are like, meh. So I get that. And I understand what our friends here on stage were doing. And I recognize that is a win for the states in some ways. I think it's not a win for innovation, which kind of blows. So, what are you going to do?
Yeah. Yeah.
Moving on to also crushing the market. The advance notice for Medicare Advantage was released and tanked the markets this week.
Yeah, dude. So this is so there were a couple of actually something you missed. I know you missed some things because we were all doing 150 different things this week. Your bestie, Chris Klomp, wrote I think an article in Health Affairs, I want to say, about like where Medicare Advantage is in relation to other Medicare fee-for-service, other accountable care, and kind of was making the point, I believe, I've only read the preview because I had no time this week, that basically like, hey, we know that all of you policy people think that MA is getting such a benefit compared to Medicare fee-for-service, but we believe that we've made enough changes now that they are at parity, and you should stop being worried about MA having like a benefit. And that was before, I guess it was last week, before the advance notice was released. And so it was like a bam, bam. And so I think those things together are like, guess what, MA, party's over.
Yeah.
I mean, it's really bad. Like, it's bad for people. Like, it's bad for sort of this industry broadly. People are very upset. A lot of people lost their shirts. Obviously, we're expecting at least a moderate increase, and I understand that. So this was really very significant for the industry.
Yeah, so this is basically no increase, and there's been some changes to risk adjustment.
Less than inflation, that's for sure.
Yeah, and like, okay.
Yoinks.
So lots of feelings on this. One is like, okay, healthcare costs are out of control. So I understand, again, much like I don't agree with the big primes giving deals to the states so that we squash innovation, whatever. Like, I do think the health insurers are still going to health insure. They're still going to make money. Like, we all know that. They lose money and make money at the same time. I don't know how it works. So I do think they're going to figure it out. And also,
I mean, I don't think they're going to figure it out. I think they're going to continue to exit the market where it isn't going to be profitable anymore. That's a
yeah,
more likely
well,
outcome.
and that's one of the challenges and the criticisms, right, of this is that the way risk adjustment is currently today done is that you have to take on high risk beneficiaries, and this kind of makes it less likely that there's going to be broad coverage. So I don't know. I get it though. Also, I know we're all blaming Chris for this, but isn't it like, how does it work, Lisa? Isn't this like the office of the actuary that actually does all this, and like they're responsible?
Oh, I'm not blaming Chris. Personally, I'm not blaming Chris. I think Chris is rightfully saying like this is the policy of the department and the way that we're moving forward on this. But I think what is in CMS is what is in Medicare office, Center for Medicare's control, so to speak, is the policy that they changed earlier last year, which was on the risk adjustment audits. So before, CMS was doing like a portion of the audits, and now they're like, we are gonna audit 100% of the plans. Guess what? Buckle up, Buttercup. Like, we are coming, like fully, like, and they are doing that. And the problem with that, again, for the industry, is they're not used to every single thing being audited, and it takes a long time. And then they go back in time, and if you do an audit and you have findings, you claw back money. That's the unfortunate part of an audit.
Yeah.
Like, hope we never get that. Please don't audit the talk show. We have no money.
We'll show our bank account. There's no
please.
In it. In fact, I just got a notice like, oh yeah, because I have everything. Whatever, it doesn't matter. Anyway, the point is we're broke.
Yes.
As per usual. But anyway, that's fine. Also, like there were some. Chris did an interview with Brian Blaze, Paragon, as well as the Trump Medicare guy, which a lot of people watched, and I thought he explained a lot pretty well in there. Although it's hard to distill all that down to quick talking points. So I don't know.
I heard good things. I mean, I haven't even watched it yet. I've had no time, but I heard that it was very good. Yeah.
Obviously, strong bias because he is my bestie, but I thought he did a really good job explaining things and getting down to the nuggets of stuff. Also, interesting fact that I think a lot of us know, but we don't talk about much: Medicare Advantage beneficiaries cost something like $70 billion more than regular traditional Medicare. So yeah, interesting things that we should all think about. In the meantime, maybe we could buy the dip in all the large health plans. I don't know. I'm bad at buying the dip. I only buy at the top of the market.
I've had all kinds of opportunities to know about this and think about this, and I've never successfully done any strategic buying. And so I just assume that there's no way I ever will.
We could do that new app that follows Nancy Pelosi's trades.
Oh yeah, I would do that.
Yeah,
that would actually make us rich.
Yeah, I probably would. Anyway, so moving on to like the private sector. So Epic gets sued yet again by new-ish company Viva. Nick Frenzer, who I actually met when he was at Epic, posted this on the LinkedIn about why he's suing Epic. This is not about data blocking or anti-competitive. Well, it is about anti-competitive behavior, but it's about non-competes. So I think non-competes are dumb. I thought our girl Lena Khan was going to abolish non-competes, but she didn't. I don't know. She also never came on our show.
This is a big deal. So, I know plenty of people, we know plenty of people who used to work for Epic, and they all say people would be shocked to hear how huge, aggressive, and like extremely negative and difficult to work with Epic is on non-competes. They have really, really strong non-competes, even though, as you can see from Nick's assertion here, or Nick's assertion is that those non-competes are not legal in Wisconsin law. But people say like these guys are really, 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 really tough on the non-competes. And that affects, even the implementation companies. So Epic does have some of its own resources who do like some of these big implementations, but for the most part, these implementations of these massive, EHR deployments are done by third-party companies, in Nordic, Optimum, et cetera, et cetera. And so they need to like hire people who have worked at Epic, and it can be really, really challenging to do that in any meaningful time frame from when they left Epic, because on the one hand, like Epic is allowing no revolving door. On the other hand, it's a private company, and like non-competes are not legal. So
yeah. Oh yeah, Pooja, our girl, she's now like running New York City or something with Mamdani. But she didn't do the job for the American people, getting rid of those non-competes. I'll also say, like, as an employer, first, two things. One, I'm not a lawyer, obviously, but like if I was Epic and like I was getting hit with 1 billion lawsuits, this is the one I'd probably settle on. Like,
listen, I you know, and I mean, Viva must have a big sort of war chest there if they're going after Epic on this. And you know, as we noted, probably very interesting to look at and see who's funding all of the different lawsuits against Epic. You might find some interesting information. If I were an investigative journalist,
which
you can
we're
bet I would
not.
do that. Which I'm not. I like my investigative journalism is like Google. And
You
then I
did a
give up
really
'cause I
great
get
job
bored.
on that Alidade thing, the whistleblower
I
thing.
know,
That was
I know.
great. That
I-
was
listen,
like,
I
you
have
sounded
the
like a real reporter.
No, I have the temperament, but just not the time. Like,
Yeah.
truly.
Anyway, and the second thing I'll say is, as an employer, retention is your job. Like, don't
Bro.
be a dick and try to contract your
stupid.
employees into like
Yeah.
staying with
yeah.
you. Like, just be
Exactly.
a good place to work, and know
Calm
people are
down.
gonna come and go. Like, what? Continuing Epic Land, Health Gorilla has released its official statement to getting sued by Epic for all kinds of different things. We have a little customer communication that we're going to share here. I thought this was a appropriately dramatic press release. What did you think, Lisa?
Yes. This is better than the previous message that they put out that was like Notes app. Like,
wasn't us.
It was like Notes app, like Instagram Reel or whatever. I didn't even know what was going on there. I was like, what is this? Like, do not publish your Notes app if you're in a lawsuit. It's a bad idea, guys. No, I mean, listen, I mean, they have to say this. I'm actually not opining on whether it's true or not. As we discussed, Health Gorilla, the company, has changed in a big way since the, you know, things that happened that were alleged in this lawsuit happened. I'm not opining either way. I don't have any inside information there. I just know that the company is very, very different today. So this is how they have to respond. Feels very existential as far as I'm concerned.
Yeah.
And like, I think you might have it in the next slide, but it doesn't get better for, I don't know.
Doesn't get better.
Yeah, it doesn't get better. So like Epic was like,
I don't know if anyone can read
Epic was
this.
like, you bet. They were like,
This is
you
to
bet.
Epic customers. This is a notice to Epic customers that we received from a fan of the show.
Yeah, a fan of the show shared this with us this morning. And, you know, like Epic is not backing down in any way, shape, or form. They're not backing off of their allegations, and they are using their network of customers, massive academic medical centers, tons of other providers to like illustrate this. And they are sending messages to them. This is a message sent to Epic customers being like, guess what? Like, Health Gorilla bad. You know, here's what we're doing. We've suspended their connection. Like, they're using their like public position and their customer list and their everything to like make this case in and out of the courts. So
Yeah.
bon chance is all I can say.
Yeah. I mean,
Ugh.
yeah. I mean, my interpretation of this letter, which you guys can't read because it's on the internet, is this is a letter to Epic customers saying, listen, we cut off those scary ass motherfuckers who are stealing your data.
Uh-huh.
Also, it implies that this is a data breach. It says you may have to report to federal and state authorities. Like,
That's right. I forgot that
honestly,
they're like, it's a data breach.
Like, yeah, it doesn't say that explicitly, but that is the wording.
In legal
obligation at the
in
bottom.
legally defensible terms, it says, we think this was a data breach. Do with that what you will or what you have to. Yikes.
We will let you know the number of names.
Yeah,
that
Michael
were
makes
involved.
makes this point, which is that each organization is going to have to now be like, what do we do?
Yeah. So okay, but before we move on from this, like, I feel like there's a lot of like business to business chatter about how much they hate Epic, blah, blah, blah. Epic's mean, Epic's, you know, causing fear, uncertainty, and doubt. But like, I feel like what everybody needs to remember is like, Epic, if they are a monopoly, even if they're close, whatever, like 50% of the nation's hospitals love and trust Epic. And I feel like we are all ignoring that fact. That like, we can all like say on LinkedIn,
it's a trusted party to them. It's
so
a trusted
mean.
party to them. They depend on Epic for obvious reasons.
They love Epic, and we saw it, Lisa, when we went to UGM. Those customers, they are not going anywhere.
They love it. They love them.
It isn't because like Epic brainwashed them. It's because they actually delivered great service compared to the rest of the market, which, may be lacking. But
Yeah, okay. Michael's saying they don't love them the best of the options. I don't know, Michael. We heard some pretty
there was
excited
love.
people. Yeah,
There was
there's some
love.
love. There was some love.
Yeah, I
Switching
would
costs
argue.
are very high. All those things are true, but I just, we heard some love for Epic. And
There was-
again, not everyone loves Epic. I get it. Best of the word, whatever. Like, but
yeah,
we'll see.
Get it.
We'll see.
But yeah, I would encourage all those very loud, grouchy people on LinkedIn, of whom I am one, but to consider what you're actually going up against, which is an organization that controls the love and direction of so many of your
and that got
customers.
signatures from a ton of those customers
right.
who joined the lawsuit, who sent a letter to ONC and like all they were able to get all those folks together. And I just, respect to them for their, advocacy and legal game. It's
very impressive.
Gotta
So
respect
right or
it.
wrong,
Gotta respect
I
it.
don't know. I would just encourage the B2B community, if you want to continue screwing up with Epic, really think about what you're dealing with.
Think
carefully
not
just what
about
the chatter is. The customers I actually want to sell to, the hospitals, all love them. So I don't know. You think your approach, strategy is good. All right, moving on here. Lisa, you had a user group this this week that was very famous and made you tired.
It was, yeah.
And you had real journalists there. What?
Real journalists there, yeah. So we had the Innovator Accelerate conference. It was like totally crazy couple of days, hundreds of people. I had a panel with two former state executives, Cody Kinsley and JC Cooper, where we talked about HR1. And then I was able to interview for the keynote Amy Gleason, our friend Amy, and Dr. Bob Wachter, talking about, AI in both clinical and administrative care, and like what the CMS ecosystem is pushing towards, what Dr. Wachter is seeing in terms of actual AI being used in clinical care. And we actually got real coverage of the event from a very real journalist who's been on the show, Armandati.
Who's been on the show? Oh my God.
And so, yeah, it was really cool, really interesting just to have that coverage, but super successful event. And that's why I need a nap like nobody's business.
Yeah, well, you're not going to get one, it sounds like. So that's great.
That's right.
And Bob Wachter, I just listened to a podcast with him about AI because I was trying to sound intelligent when we interview Neil. So
he's got a book coming out.
It was about his book. It was about his experience with AI over many, many years. And he was very thoughtful.
We actually did a signing of his book afterwards, and we had like a massive line. His book hasn't even been released. We had like pre-release books. It was so cool.
Gee, did you?
Yeah. It was a great stitch. No, I didn't. Sorry.
Well, that's okay. Maybe next time. Okay, so news from the People's Republic of California, which is going to be splitting off soon from the United States of America, and is starting slowly but surely, unless Gavin Newsom is elected president of the United States in 2028. Basically, California is doing everything Trump is not doing on healthcare. So continues to be the case here. Maybe they'll just join the WHO like on their own. I don't know. I don't know what's going to happen.
Yeah, I think it's great. I support it. Good job.
Yeah, I mean, God bless the states is all I got to say about that. The states do what they want. The states do what they want. Unless you're Minnesota, in which case you don't get to do what you want. That's not great. Okay, so some acquisition news. Sword Health acquired a competitor. That's exciting. I think this was like I forget. I actually cut off how much, many millions it was because they published it.
It was a lot. So Kaya was actually also a company which is based out of Munich, Germany. That's why I knew about them. Is a German, it's very rare that a German health tech company or even European health tech company gets acquired for big dollars. So this is interesting. Sword is also a European company. They were originally headquartered in Portugal or founded out of Portugal. I think they also are headquartered in the US as well for a long time. But these are both like European roots companies.
Yeah. Oh, and I can't find how much it was. It was a lot of money. It was very public. Oh, no, 285 million, which isn't like
for a European health tech company, that is a lot of money. I'm just saying.
God bless them. Congratulations to all involved.
That's right.
Oh, this was a good gossipy rumor from.
I love this. I haven't seen it anywhere else.
Okay, to be clear,
no.
look at this logo. It's like the talk show's logo with the weird eagle, could be a duck.
This is like we made it up, basically. Like there's no.
Lisa's newspaper.
No, I swear, you guys, we did not make this up. And also, I would say like 5+ people sent this to me individually, just to be totally clear. Everyone's like, "Oh my god!"
Oh my god!
I don't know if this is
there
true.
Any merit to this whatsoever? I mean, it's great gossip.
I don't know. You know, honestly, like Oracle does see its future in like being like the big daddy of all the AI data centers forever. Like, I mean, that is like their most like long-term value play is like no matter what happens as data centers, you know, grow, as like AI data needs grow, Oracle is extraordinarily well positioned / the only one positioned to make a huge amount of money on this. And so you know, I see that from a perspective. I don't know how things are going at Oracle Health. We've got lots of friends there. Feel free to give us some tips.
Yeah, call
you know,
us.
Whatever.
Or like, you know,
call
however
us.
You want to, you know,
text
put
us,
a comment
signal
on
us.
LinkedIn. I don't know what's going to happen.
Yeah.
But this would be exciting news if it was true. It just might not be true.
Yeah.
Okay, so moving on to hilarious things on the internet. This isn't hilarious. I think a lot of wellness influencers are sad about this, but a new study came out. Seems actually legit, saying sad for us. It turns out all of our longevity solutions we buy on Instagram actually aren't going to extend our lifespan, and really most of it is genetics.
Which we kind of knew. Just be real.
So this is the summary from the stat newsletter this morning. Someone check on Don't Die founder Brian Johnson. Otherwise, read this great story. I love the stat people.
Yeah, I'm doing. I have, you know, I have my grandparents. My grandparent who lived the longest died at 96, and all my grandparents drank a huge amount of alcohol and smoked for many, many years. And so I don't know. I feel pretty good about my chances right now.
Yeah,
not being a smoker.
Also come from a line of Eastern European alcoholics. And I will say, sadly, they did not live that long, so I might be screwed.
So just drink up. Who cares? Who cares?
I mean, it's out of my control. Yeah, I do have
control.
Cool Moms Book Club tonight, and it is actually Cool Moms Wine Club is actually the real deal. So, you know, we'll just see what happens.
Nice.
Anyway, so sad for everybody. One or two more things. I think this is the last thing. Sorry, Neil, don't worry, we'll get you. Last thing here is with all this direct-to-consumer stuff, which isn't just related to longevity movement, but in some cases like lack of access and all that. It turns out, like according to this amazing Stat News article, there are not a lot of protections around that. Like oftentimes not covered entities, your data isn't covered under HIPAA in this case, and could be potential for it being sold to even someone who wants to maybe insure your house or not. So lots of risks identified in this article. I thought that was interesting. And I actually was like, oh, well, no, we have those laws like GINA, like for DNA tests, but these are not DNA tests. So I mean, something to consider, America, as you like me, go on the Instagram, get your targeted ad and click buy now with Apple Pay. You know, as always, use your brain. Last bit here. Yep, we're going to ASTP. We'll be there. It's unclear if we'll actually go to the conference or just be in DC. We'll see what happens. And then we are going to Vive. Like Melissa told you, we're doing 2 shows because we have to do our real jobs and do speaking stuff. So call Melissa if you want to be on the show. Also HIMSS, which is somehow right behind that, which is hilarious. Okay.
I always say I'm not going to go to Vive and HIMSS, and I always do it.
Yeah, you always say you're always going to go. Because we have real jobs and we have to do it. Neil,
I know.
How are you doing?
I'm great. That was really entertaining.
A lot of people say they wish they could jump on during the news show.
You can do it. It's in your hands.
We just feel like we say a lot of bullshit and people might
That's
be
true. We do.
Okay, Neil. So one of the many reasons you were invited to this show, other than us liking you, is so we were at JPM at a party together, and you were talking about a roundtable you participated in with some federal leaders and VCs talking about like how do we encourage AI adoption in healthcare. Oh no, am I freezing again? Of course I'm freezing.
No, you're good.
Whatever.
You're
Okay,
good.
great. And I was kind of, because Lisa and I trash talk AI a lot. Like obviously we're into AI, but we kind of trash talk some into it sometimes, maybe. And you were just talking about what we actually need to get AI adopted, and then like why we need AI adopted, which is something we talk about a lot too. Like, let's talk about the why. So with that intro, please tell America who you are, because I'm sure there's at least, my mom watches, so at least 1 or 2 viewers. Tell them who you are, and then just like tell us some stuff.
Hi, Kat's mom.
She's here.
Yeah. So I'm Neil Patel. I lead the venture team at Redesign Health. We're a early stage investment firm. By early, I mean like as early as possible. We work with founders before they have ideas. We work with founders who have ideas. We're the first capital in. And so it's fun. It's super risky, but it's the most fun thing that I've done. It was funny you were talking about this book that you guys mentioned. It was just sitting here, and I picked it up at the party that we went to, and it was just on the table. And really funny story. So like one of the guys that was like working the party, that like the Define town hall party that we went to, he was like, I saw a bunch of these people with these books. I'm like, wow, this is a really well-read crowd. And then I noticed that they were all the same books. So they must have just gotten these books for free. And there was just like one sitting on the table that someone left behind. So I picked it up and took it. So I have it. I've not read it yet, but I'm a fan of Dr. Watcher, so I'm looking forward to reading it.
Yeah, he told us he was, really trying to get like not just like a line in the sand, but like where are we really right now with the actual uses of AI in clinical care and what's actually happening versus like a bunch of random hype on the internet.
Yep.
Yeah.
So we'll see.
So yeah.
So
like,
what do you want to talk about?
Well, tell us like, why do we need rapid expansion of AI in healthcare? And then how?
Okay. Yeah. All right. That's a lot. So I think there's two kind of dimensions of AI in healthcare. I think we're just scratching the surface on both, and like I would say kind of scratching actually on one side, which is like anything that is, call it non-clinical, and then not even really scratching the surface on clinical AI. So like administrative AI, clinical AI, 2 different categories of kind of needs that they're addressing, as well as importantly, and I think where the discussion that you and I were having at that party was around like what needs to happen for clinical AI to actually go from just above the surface to scratching the surface to actually making an impact. So up until now, like the industry, call it post ChatGPT moment to where we are today, has been like fully focused on administrative applications of AI. You see, revenue cycle, back office, patient scheduling, things that are assistive, so like scribes, things that have human in the loop, things that are like getting closer and closer to like where everyone really thinks that we can go with this, or at least everyone that I talk to in my bubble thinks we can go with it. Not that I don't talk to many skeptics, because like that's not fun. Where the clinical side is like probably where the biggest impact can be, because what it can do is like, you think about the dream of what are we all trying to do with healthcare technology. It's like improve quality, improve access, reduce cost, right? And like I love humans, and I think they're smart, and physicians are great, and they're well educated, and my wife's one, so like she gets mad at me when I talk about this, but like they're not everywhere. They do cost money, right? And so everyone that wants to see one can't see one exactly when they want to see one. And so it's like the mindset that I've been thinking about is like, we've designed a system of healthcare that operates in a constraint mindset where things actually cost real money, and we have to like ration their use. What technology and AI can do is like move us to an abundance mindset where like we don't have to think about how much things cost and whether or not you should have it, or whether like you deserve the care, right? Whether you can pay for the care, all these sorts of things. It's I'm simplifying it to some degree, but I think that's kind of what it does. It's like you flip this mindset around like optimizing who needs to see the person, or optimizing resources to ROI, and you say, what if cost wasn't a factor? And I'm not saying it's not, but like it's a order of magnitude potential difference in terms of like unit cost of delivery of like a minute of physician time or a minute of AI time, right? It's obviously not nothing. Compute costs money, technology costs money, people have to make money, there has to be profit. But like that's the notion that we're operating in, and that I kind of have built my our investment thesis at Redesign around, is like what does that mean? If that were to be true, what has to happen to get there? What types of technologies, types of businesses, what types of assets are going to be most ripe for this kind of change? And like, you know, everything goes through cycles, right? Like, you know, when I met you in your collective, it was like, you know, it was like pre-COVID, right? And health systems were good buyers of things. And when you needed, like, you're still selling into an IT budget though, right? And what's changed now, and we see post like nursing crisis, and, you know, that whole time post that COVID era when hospitals were like really under strain and like dying from nurse labor cost, they've kind of moved past that a little bit. Not to say it's great by any means, but like now technology companies are selling into labor budgets, and they're selling into operating budgets. And 95% of health system provider expenses are in operating budgets versus IT budgets. And I'm like, that's somewhat of an average. It obviously ranges, but it's the bulk of cost, right? The bulk of operating expense is not in technology. And that is kind of where I see significant opportunity. And last point on this before I'm sure you guys want to say something is like, you know, what's the average operating margin for a health system? Like,
not a lot.
Very low, but it's also intentionally low in some cases.
Sure. But like, does it need to be as low as it is? And if it was higher, I'm not saying that it needs to go into salaries of administrators, but it could go into community benefit. It could go into, you know, things like that are, I understand might be skeptical, but like it doesn't need to be 1% to 3% is what I'm saying. Right. Like,
sure.
And
but a lot of these are nonprofits, so they're intentionally, you know, not having a high operating margin. And then as much as I love what you're saying, I think the reality, like meeting the reality, is that a lot of that money will likely go into, you know, administrator salaries and maybe not hiring or, you know, or delivering care in a different way or community benefit, right? So like, I hear you and I understand what you're trying to get at, but I also think like if past is any guide to us, sometimes when you squeeze the operating margin, you get out money that goes into, you know, if it's a for-profit, a stock buyback, or otherwise a nonprofit into an administrator's or CEO's salary. So one thing I hear, so going back to what you just said though a minute ago, I want to say, like, I think I am very supportive of the idea broadly that, you know, we should automate as much as we can to save time. But then anytime you talk about what you're talking about, which is taking money out of the operating side, you're talking about in many cases like people's jobs, which is not. It's not like I'm actually saying that in a neutral way, right? I just, anytime that we do something like this, we potentially threaten someone's job. So how do you envision like the power dynamics around that, which I think is a real issue that we certainly haven't solved it yet.
Yeah.
No, yeah, this is something I think this is a labor in general, right? Like white collar labor. This is like something that I think society needs to confront. Health systems, and I know we're talking about health systems because I think that's where like the biggest opportunity probably is at the moment for this kind of transformation. Like, you know, in a lot of markets, a lot of cities, they are the largest employer. And, you know, if all of this transformation plays out, and Lisa, to your point, we automate a lot of stuff away, there will be real job loss, right? Like that's I don't say it lightly, but it is like, it will happen. I think it's going to happen across all sorts of industries, but like small towns in which a health system with like 5,000 employees is like the largest employer in town, that's going to be a real problem, right? And so kind of going back to what I was thinking about before is like, yes, they're nonprofits. Hopefully they don't go into administrator salaries, but like if we can figure out some situation where like it doesn't just like sit in balance sheet reserves and it gets reinvested into upskilling, reskilling of labor. This isn't going to happen overnight, right? And so I think there is a transition path. We actually just started a company with a health system in rural Georgia that is focused on subclinical, non-clinical workforce, like career laddering and reskilling. Because this is like we think this is a thing that needs to happen. People need to be retrained on how to become effective users, adopters of AI. I think one of the good things about the OBBA was this AI education tax credit. And like, I don't think that health systems are really thinking about how to take advantage of this to be able to train the workforce. I mean, there's so much things going on. So that's one of the things that this company that we just started is the founders are working on is like, how do you set up the the financial rails, the audit trail, the actual content to be able to take advantage of this so that you can help your workforce in a lot of ways. There's other issues too, but like around entry level attrition, all those sorts of things. There's low hanging fruit, but there's a long term implication. So I appreciate you bringing that up, and I agree it's something we have to think about.
Yeah. Well, one of the other things in Dr. Walker's book, it was about, labor, and it was about, is AI coming for the physicians' jobs? And I think we've heard a lot about that generally, right? It's like, it's going to replace physicians who don't use AI. It won't replace physicians who are using it, that kind of thing. There was also the argument, and Lisa, you said this before too, on the clinical staff, at least, potentially not an administrative staff, who probably are at risk for job loss, but on clinical staff, we simply cannot get enough of them right now. And we won't be able to train enough of them fast enough to fill the gap. So this kind of is, and some more, I'm not an abundance mindset person. Love the book, here for it. I'm more of like a let's always
anti-abundance.
Let's just there. Just talking
Cat
about
hates
like
abundance.
My alcoholic Russian relatives, like they're always coming for us. But anyway, but I think that is like a pretty catastrophic viewpoint, right? Like, if we don't do something about it, we have no other options. So this is kind of what we.
But I'm worried. But from what you say, I'm worried about that too, because I think a good solution for us on the workforce side right now is that we don't have enough people, and we need to augment with workflows that might be technology or AI driven, right? We must absolutely must. But if administrators think like, yay, I've got this technology and I'm going to stop hiring or stop, putting humans into care positions, as we've discussed before, probably 100 times in the show already, like I think that's a bad outcome. So I say like keep and continue to grow as much as we can, the human side, and put people in front of that. But also we desperately need to augment with like better data, better technology, better workflow. So that's at least my take, Neil. I'd love to hear how you think about that side as well.
I completely agree with you. I think this is a controversial opinion, but like, why do we have mid-levels? I
know why. I have an opinion why. I don't know why.
I mean, this is my opinion why, right? So this is not I'm not the definitive authority here. And this is, again, no offense to mid-levels out there. But the reason that entire category of job was created was because like we don't have enough physicians, right? And there are things that physicians do that they don't necessarily need to do. And so it's like, I have a viewpoint that like if AI actually is able to do what we think it can do over the course of time, I'm not saying like right now, but like I think what we'll end up having is like super panels of physicians with like AI clinical people managing stacks of what a physician does. And you may also have like mid-levels using AI as their kind of co-pilot, because like, and there's a company called, I think, Altitude that's
I just heard about them. I just got an ask from a large FQHC group saying, have you heard of them? And are they legit? So tell us.
They're totally legit. Okay. Yeah. Prabjot's awesome. He knows what he's doing. And
his name, they're like, this guy is legit.
I know that dude. Yeah. He's great.
Yep, okay. Exactly. So I'm very happy that he's
will report back. Yeah.
Yeah.
But it's like, think about it, like that, what he's doing is basically like, there was a boom in NPs that, there's NPs that have like 20 years of experience. They are amazing. There's NPs that have 2 years of experience with no clinical training before they enter the workforce.
This is my opinion. Exactly, Neil. We're on the same page. Yes.
Yeah. So that is the problem, right? Like we have this bimodal distribution of quality of the mid-level workforce. And I think that is the problem. So AI has the potential of helping kind of close that quality gap. And that's what Altitude is doing, right? There's a longer term view that like, that is still only a Band-Aid on this problem of under-trained workforce, right? And so it's like, what happens over the course of time is kind of the thing that I've been thinking of, is like, that's the potential of this kind of, panel. And I actually had at Health, I was talking to, Paula at Oak. She's the Chief Population Health Officer. She's awesome. Mm-hmm. But they were talking about how they've kind of constructed their panels, and they just started experimenting with full NP, like no doctor, NP only, and kind of saying you manage completely to the protocol. And they actually found that those patients had a much higher cost of care because the clinician did not exert any judgment in, saying, like, you don't need this diagnostic because you don't need this level of care. People tend to practice defensive medicine when, it's a liability thing, right? Like people practice defensive medicine because they get, could get in trouble if they don't. And in these kind of MA panels, what you're seeing is that, at least they saw, was that people were fully protocolized. They weren't saying you don't need this, you always need to do this thing. They're just kind of going over the book. Whereas physicians, again, I don't love all physicians either, but like physicians were like, you know what, maybe you don't need this, more like pushing more on the art versus the science of things. And that led to, lower cost of care. So like now pull that argument forward. What if you just had a bunch, like took a panel of, it was probably 500 because these are complex patients, say, you know what, you can actually manage 5,000 patients because you have, a bunch of little AI things running around doing all this stuff for you. All you have to do is exercise judgment where you need to.
Yeah.
Mm-hmm.
Yeah.
Yeah. I mean, I think that's true on the just the NP side, but the mid levels, again, this is like that is the structure of medical education in the US, and the guild-like behaviors, one might call it, limiting the number of doctors who can be graduated and trained, but also that other countries with relatively similar medical systems have the concept of a junior doctor who's doing more training, over time, but also still practicing just like a resident, but with a different structure and less time to be trained before they're allowed to start working essentially as an apprentice. And we made a decision, and then we've, plussed it up like we do. And it's exactly what you say, right? An NP who's been practicing for 10, 20 years has exceptional experience and information and can be really, really valuable. And somebody who graduated maybe from a school that is mostly online and has no clinical practice is not the same quality of care provider. Please don't cancel me or kill me.
Well,
100%.
So Neil, we only have a few more minutes with you, and I want to switch over to the how we get this done, right? And one of the conversation we had is like, I think I was saying Sebastian from ABC wrote this article with a bunch of other people months ago that I was like, it was more like fee for service. How do we bill for AI? And I was like, nah. And you were like, that's actually a good idea. And then you were talking about liability shield.
Yeah. So there's like, I think there's three vectors at play here. So one is regulation, and so like FDA, it has a big role to play, obviously here. One of the things that they pushed out in early January was around just like how they're deregulating a lot of things and clarifying what is, SAMD versus not, what's clinical decision support versus what is not. The thing that is like really interesting about this is like, you think about the existing, software as medical device framework, which uses like pre-market authorizations and assumes that like once a device is on the market, whether it's algorithm or not, it's static, right? Which is obviously not the case for anything that is generative. And like they know this, and I talked to Shantanu, and he's working on a next framework for it. But it's like that's the thing that's going to happen, because like obviously they push software up. Like this is software. Software has development cycles and continued learning. It is deterministic, which is something that obviously traditional algorithms are not, right? And so it's like there are changes that need to take into account. Let's assume that we solve the constant live monitoring idea of it. The next piece is going to your point, and what we talked about is like, what does liability look like? And there was an article that was just published actually in JAMA, or as a viewpoint that was published in JAMA that I saw. And I'm like, they nailed it, because they said, instead of thinking about like, what's how does the software get coverage? How does it, what's indemnification look like? Not exactly how you talked about it, but it's like, think of the AI as a licensed practitioner, and just give that licensed practitioner like some level of malpractice insurance. And that's the thing that I've been thinking about, is like, what does it take? What are the, and we talked about licensure because like, the doctor license is done at a state level, right? And so like, that's one of the impediments to scale. The other thing that's a problem is that tort law is done at a state level, right? And so like, we have all these issues that like, yay, federalism, but like, it's a problem for scaling of these things. Like states have different AI laws. Like this is going to be a real issue until we kind of try to figure out how to change at the federal level, which, doesn't seem like a possibility, because that's not where we're at as a country. Like we're not going to all rally around this. And so it's like we can, at least what we can do at the FDA level, what we can do to Sebastian's point at CMS is, we know how to regulate it. We say call it approved, right? So it has clearance from that standpoint. And then CMS says, this is how we're going to pay for it. And then states figure out what tort laws apply and what is the licensure requirement. Like all those things kind of have to come together. And I don't know what the order looks like, but I think it's FDA, CMS, and then state. Unless we have like the Doctronic like things that Utah did, which I thought was really cool. But it is very, very limited, which is fair. Like auto refills of prescriptions, like whoopee, right? I'm sure there's more to come, but like you start there, you figure out what the liability looks like, and then you figure out what we think we're kind of working on. Like, what does malpractice insurance look like here? The other piece is like you mentioned, Lisa or Kat, like around like doctors with, I think you do, Kat, like doctors with AI, right? It's like doctors that don't use AI, maybe they should have potentially higher malpractice insurance because they're not using all the tools available to them, right?
Yeah.
And analogy that I think about is like, if you have self-driving or you have a car that has, sensors and you decide to turn it off because you just want to go cowboy, like you should probably have a higher insurance rate than someone that's using all the, sensors and crash protection and lane avoidant, like lane departure warnings. Like that is even if that driver is not safer, they're using a safer car and they should have lower insurance.
Right. Well, I
speaking of the insurance, though, Doctronic, doing the refill prescriptions, they apparently got malpractice insurance, which is they didn't have to, but they did.
I think that's really smart because the other thing is like there are in technology, right? It's like if you try to isolate who's at fault, it's not like a singular monolithic stack of tech, right? It's like it's not all one company. It's like Doctronic sits on top of a LLM that sits on top of a cloud provider that sits on top of whatever, right? And so it's like what went wrong, dissecting all of that, just like assign it to the top and say you are responsible for everything below you. And that's effectively how licensure works. The other thing that's really cool about if you think about this like parallel to physician licensure, it goes back to what I was saying about like these are learning models, right? It's like physicians have to maintain their licensure. They have to do continuing medical education. They have to appear for boards again. They have to credential over and over again. I'm not saying that system is perfect, but like let's just figure out the AI parallel to this instead of like saying, okay, we got to completely come on something new.
Yeah. And I know we're almost out of time, but interesting your thoughts on this since we are the United States of America and our states are great and get to do what they want. Do you think like a Utah doing a great job with some of this stuff is going to be like the standard setters that other states follow? Or how do you see, even our current environment, how do you see all that stuff going?
Yeah, in that meeting, I asked the question of like, what can the federal government do? And the response was, somewhat encouraging. It's like, we can work behind the scenes, but like maybe states can partner together and kind of like, instead of saying, Colorado and Utah and everyone has to come up with this independently, like, is there some sort of shared framework that they can like copycat to some degree? At least like, adjacent states. And I mean, I don't know. I'm not too confident that we're going to be able to get something there, but who knows?
Yeah, that's hard. The state's got a lot going on right now.
They do. They got a lot going on.
Yeah. Well, Neil, any parting words with our million fans or just my mom before we sign off for the weekend?
I will see you all at Vive.
Very true. Let us know if you want to come on our show. We'll be there.
Crazy show.
Yeah. It'll be just like this, only worse.
Amazing.
Yeah. Well, thank you for coming on the show. Awesome to hear your thoughts. Yeah, I really appreciate it. Have an awesome weekend.
You too. Bye.
All right.